Tracey Cawthorn. She's giving us a presentation today on dementia, diversity, and demographics. So give her a welcome applause. Thank you so much.
Okay, last speaker of the day, no pressure. All right, I'm trying to entertain a little bit here. Okay, so I did most of my training here, so I have been at the Health Science Center at the VA for roughly 10 years, but this is my first year as faculty, so I'm primarily over at the Health Science Center. And I creep my way back over here. So, okay, so we'll start out with talking about a case. This is a gentleman whose family brought him in. He's a 71-year-old male, and they're basically describing kind of a 2 to 3 year worsening history of worsening memory, difficulty taking care of himself. They're having to do more and more for him as far as taking care of bills, managing his medications, getting him to and from places, transportation issues, meals, and things like that. So he's supported by his family, like I said, but the problem comes in because lately he's becoming more of a problem. And by that I mean he's becoming more delusional, a little more agitated. So if he becomes a little more paranoid and they try to redirect him, no, Dad, that's not really what's going on. He's becoming more angry. No, you're calling me a liar. You don't know what's going on. You're a part of it. And so he's becoming more of an issue. He's also starting to wander around. There hasn't been any physical aggression, but this kind of prompted them to bring him in. And so this is kind of one of the typical cases that we would have for someone to come in with Alzheimer's disease. Generally, it tends to be a little bit later like that. So why is dementia important? There is about 36 million people who have been diagnosed with dementia in the United States, and this number is expected to double by the year 2030 and more than triple by the year 2050. Between 2% and 10% of all those cases of dementia actually start before the age of 65, and that's more or less related to more of the familial type of Alzheimer's dementia. Right, so that's one of the issues that we worry about. Dementia is one of the major causes of disability in later life. It causes people to require more of that home care, whether it be family, home providers, nursing homes, skilled nursing facilities, more hospital care, acute hospitalizations. 11.9% of the years lived with disability are due to non-communicable disease, meaning that it's strictly dementia care. It's not because of pneumonia, it's not because of anything like that. And it's the leading cause of dependency, as I kind of indicated before. So the total estimated worldwide cost of dementia in the United States was $604 billion in 2010. In high-income countries, informal care was about 45%, formal social care 40%, accounted for the majority, while the proportionate contribution of direct medical costs, such as those acute hospitalizations, actual medications, and things like that, was about 15%. Okay, so most of that care is going into the caregivers, the family, who's going to kind of help with meals and take care of them during the day and things of that nature. So let's talk some statistics. So the United States, 5.2 million Americans of all ages. I'm sorry, before I said 36 billion, that was worldwide. Sorry. So United States, 5.2 million Americans of all ages have Alzheimer's disease. Between 2000 and 2010, deaths attributed to Alzheimer's disease had actually increased about 68%, while those that were attributed to the number one cause of death, which is heart disease, actually decreased about 16%. Age 65 and older survive an average to 4 to 8 years after formal diagnosis of Alzheimer's is made, yet some can live as long as 20 years, and that is kind of debatable and mostly related to the time that they're diagnosed and if they have that familial type and things like that. So in talking about Texas, in Texas alone, there are currently 340,000 people who are living with Alzheimer's disease, And by 2025, that number is expected to increase to probably over 500,000, but we documented as 470,000. So, why is that? Why are we worried about the numbers of Alzheimer's patients increasing? Well, the risk factors. So, a lot of what I'm going to talk about will kind of overlap with what Dr. Shedd was talking about before. But the main risk factor for Alzheimer's disease happens to be age. And then other risk factors, as I mentioned before, family history and genetics. There are certain chromosomal abnormalities that you can have that kind of increase your chances of developing Alzheimer's disease, more of that familial type. Women tend to be at a higher risk, which is partly because they live longer. And then if you have developed mild cognitive impairment, and that means that you have some difficulty with your memory or some slowing of cognition or something like that, but you haven't actually lost your functionality, and so you don't quite meet that criteria of dementia. But your chances of developing dementia, in particular Alzheimer's dementia, will increase. Lifestyle and heart health, so lack of exercise, smoking, high blood pressure, high blood cholesterol, elevated homocysteine, poorly controlled diabetes, and if you don't get enough of your fruits and vegetables, like that commercial, that gait commercial, in my head. So things like that are linked to kind of increasing your risk. And then things can be like lifelong learning and social engagement. So your higher levels of formal education, if you have a stimulating job, your more mentally challenging leisurely activities, playing games, musical instruments, and frequent social interactions can actually reduce your risk of Alzheimer's disease. And it can also help when people that have been diagnosed with Alzheimer's disease. So that's why we try to get them into the senior centers and into groups and things like that. We try not to let them stay at home too much. Okay. So just a side note, because usually this is where I get a lot of these questions. So there are a lot of studies that are going on as far as the prevention of Alzheimer's disease. So there's a little bit of evidence that you can reduce your risk by eating right, exercising regularly. There's no evidence to suggest definitively that the intake of the antioxidants or vitamins or flavonoids, vitamin D, things like that can prevent Alzheimer's disease. They're still looking into it, it's just not definitive. Low cholesterol, low fat diets that are rich in fish and omega-3 acids can be helpful. Looks like, but there's some evidence that light to moderate alcohol use can be protective against dementia, but you can't really advertise that too much to say people, right? So take that to the extreme. Let's look at the population in Texas. So between 2000 and 2030, this was actually done in 2009. So from 2000 to 2009 is where it was the actual, and then from there it's kind of projected. So you can see that the 60 plus years is kind of on the rise there. Is the point of that. Okay. So, there are other cities in the U.S. that have increasing populations, but Texas seems to have a lot of cities with large increases, especially in 2011, 2012. So Houston, San Antonio, Austin, Dallas, Fort Worth were on the list of the cities with the largest increase in 2011, 2012. So while a lot of these people are going to be younger, I guess young adults, middle-aged, we also have to consider the fact that they're living with their older family members or they're retiring here or something like that. So they're part of our older population as well. Okay. So this is kind of looking at the statistics of how many people have immigrated to Texas. So we have international and we have state to state. So we can kind of see that bump in the middle there. Anybody remember or have an idea? What that is? Yeah, so there's something that happened there.
Isn't it Hurricane Katrina?
Yeah, so Katrina happened about that time, around August, and so a lot of people had migrated here, not only from Louisiana, but also from, I just blanked, what's that state? Mississippi. I know it starts with an M. So I thought it'd be kind of cool to look up some reasons why Texas looked interesting to people, because obviously that's not the only reason, was hurricanes, right? So I thought I'd do like a David Letterman top 10 kind of thing. But I found an article that actually said that there were more jobs in Texas. It's cheaper to live here. Land was cheaper. There's lower taxes. You get to pick pick your own big city, with Houston and Dallas kind of being the major ones. Austin was named by itself because it's Austin, I guess. It tends to be more family friendly, fewer rules. Texans are normal people, which I thought,
Normal people.
and then Texans don't leave. So it's kind of like, if you were born a Texan, you'll probably die a Texan, and then people that move to Texas stay in Texas. So that was kind of the thing. And then the newest reason, which is probably the most important and the most dear to my heart. Everybody's got to come here now. All right. So looking at kind of the state geographically, right? So a lot of the people, this is kind of the Hispanic people in Texas, and you can see that most of the growth of the Hispanic population is based down south, kind of in the valley area. So with McAllen, Edinburgh, and Mission being kind of a burst over the others. But from 2002 to 2007, South Texas region's population increased at 2.1% annually, and which is slightly faster than the state's 1.9% annual increase. And growth in the metropolitan areas of, again, McAllen, Edinburgh, Mission, and Laredo and Brownsville, Harlingen outpaced both the region and the state. McAllen led regional growth, increasing about 3.3% annually. Corpus trailed, and growing by just over 0.6%. But South Texas's population growth is projected to slow from 2007 to 2012, but still outpace the state as a whole at about 1.4%, as opposed to the 1.2% as for the state as a whole. And again, these are kind of actual and the projected populations. So let's go back to our case. So in the case of our gentleman here, what issues or what treatment goals should we, as the healthcare provider team, I guess, be concerned about in helping this family? What are some of the issues, I guess? The problems?
Safety.
So safety, so we're worried about his wandering, right? We need to do something about that.
Does he live with the family or is he on his own still?
He lives with the family. Definitely, so caregiver support, we have to make sure that we're taking care of, in this case, primarily his family, and caregiver burden can be a huge issue in this family. Anything else?
Decrease the delusional and agitated behavior.
Yeah, so the psychiatric concern of the psychosis and the paranoia, that's going to kind of contribute to that caregiving and safety, actually. Absolutely.
Does he drive or have a gun?
Good points, yeah. We need to know that, for sure. So all of those are really good points. So we need to look at his mood disturbance. Is he depressed? Is he anxious? His cognition. So we kind of need to figure out if this is an actual dementia, because we always have to kind of rule that out, right? So dementia we can usually diagnose with our cognitive testing, which you've probably heard about earlier today. But there are some times where people had a slip and fall and they've had an acute head injury, or they've had, some type of thyroid abnormality or vitamin abnormality or something like that. So once all that stuff is kind of out of the way, then we can actually focus on the cognition. The behavioral disturbance, which affects the safety of this gentleman. And then again, the daily care, which we will focus on our caregiver support. And something that we always want to bring up earlier, sooner than later, is the end of life discussion, which is always kind of a difficult conversation. And we'll talk about this a little bit later, but some cultures are a little bit more open to that than others, so it's sometimes difficult to do. So there's one, let's see. Okay, so there's another piece of information that we don't have about this gentleman, that anything that you would think is important that we should know in determining his plan of care. Keeping in mind that Dr. Shedd and I are both talking about health disparities and social care.
Health issues, insurance.
So yeah, that's all part of it, but kind of his social history, right? So this gentleman is born and raised in Mexico. He immigrated in his early 20s. He's been married one time, 40 years, lovely wife. He's got 3 adult children. They're all very much involved. One of them lives kind of down the street, so she's kind of the primary person, but the others one other lives in San Antonio, the other lives kind of like in Burnaby or something like that, but they all do what they can. They take turns. Very supportive family. 5 grandchildren, but he worked as a laborer, so he doesn't have very much education. He speaks very little English, and currently lives with his wife. Like I said, he's got a lot of the home care though. Okay, so and the approach to the treatment plan, kind of knowing a little bit about the family and their background becomes important, because before we can even start to have conversations about treatment, we have to talk about diagnosis and kind of what we think is going on with him, and should we disclose that to him. So if you were in this case, how would you go about that? Would you have the discussion in front of the patient? Would you have him leave the room? Would you talk to the family separately? How do you normally handle that situation?
Did you say he was diagnosed with dementia or not?
Yeah, so we kind of did everything and kind of figured out it's more of a dementia.
I would do both. I would talk to him and the family.
Okay.
Do it together and separately and see what he wants. He's in a lucid state. He might still be able to tell you what exactly, his values are, his goals are, what he does and doesn't want. And then talk to the family and see where they match.
Right, so that's a good point. So we kind of have to still consider the fact that he's able to make his own decisions. Maybe he's not that far advanced yet or something like that, but. Okay, anybody else have any other thoughts about? How do you feel about not telling the patient what's going on with them? If that's okay, or?
I would say, how does the family feel about that? Because Hispanics a lot of times like to protect the person who has the illness.
Right, so, and it's not only the Hispanic culture, there are other cultures too. Primarily, I've seen it in Asian and Native American, where there's something called therapeutic non-disclosure. And so basically it's, if the person has, hold on. Okay. So if the person has like a terminal illness or something that's, maybe treatable but not curable, or it has a stigma or something like that, they don't want the person to know, because it just kind of puts them in a bad state of mind. It'll crush their, optimism and all of that. So, that is definitely something that you need to have a grasp of with the family before you even have that conversation. So yeah, so you would pull the aside and kind of understand the background of the family before, even starting to have that discussion. Certain people have different views of the medical community. African Americans tend to be very mistrustful of the healthcare system, and so that can sometimes be an issue. Religion can be not a barrier, but can be needs to be considered and included in that discussion of treatment plans, because people are either gonna go and take their medication, or they're gonna pray, or, you know, they need to be open to that, so you know what they're doing. They're just prescribing medication, hoping that they're taking it, not to kind of discredit, you know, their faith or something like that. Okay. So, what contributes to varied healthcare needs? So the population change in Texas that contributes to diverse healthcare needs, lack of access and availability of services and how that impacts service utilization, and then social, economic, racial, environmental factors contribute to health disparities. So if we look at the definition of health disparities, there are differences that occur by gender, race, or ethnicity, education or income, disability, living in rural localities, and sexual orientation. The overall rate of disease, incidence, prevalence, morbidity, mortality, or survival rates. There's a significant disparity in the overall rate of disease, incidence, prevalence, morbidity, mortality, or survival rates in the population as compared to the health status of the general population. Health disparities primarily affect African Americans, Hispanics, those in geographically underserved regions, and low-income individuals and families. So let's look into that. So, 2007, 81% of the South Texas population was of Hispanic ethnicity, both white and non-white Hispanics, compared to 36% in the state overall. Laredo is 95% Hispanic, McAllen 89%, Brownsville 86%. Non-Hispanic whites accounted for 16.3% of the South Texas population in 2007. And by 2012, the Hispanic population was projected to rise 82% in South Texas versus 37.6% in the state as a whole. It actually increased 86%. So we actually have more than that. So looking at kind of a demographic map, you can kind of see the darker purple areas, they're very dark. Purple area means greater than 50% Hispanic, and that location, this is kind of broken down by county. You can see that it's kind of concentrated down in South Texas, over in El Paso, kind of on that western border area. Let's see. And then, yeah, and then kind of scattered up Panhandle a little bit. So the concentration of Hispanics in the South Texas region is more than twice as high as the states and more than 5 times higher than the nation's. This pattern can be illustrated by common measure and economic and demographic analysis, the location quotient, which is a ratio that can be used to compare the concentration of a given group, either by ethnicity or age, for instance. Keep pushing that button. In this case, we're doing by ethnicity. In a specific location with a state or national average. So a location quotient of more than 1 indicates that the demographic category is overrepresented in the region under study compared to the state or national average, while a location quotient of less than 1 indicates that the demographic category is underrepresented. So you can see we're well above 1 in that South Texas area. So what factors are contributing to health disparities? We have the language barrier in the case of our gentleman, education, income poverty level, health care, meaning insurance, projected age distribution, physical and mental health, access and availability of services, and social, economic, and environmental factors and disparities. So again, kind of, I guess, reiterating the points that Dr. Shedd was making in regards to the healthcare disparities. So let's talk about language. So this is specific to the United States, obviously. So this is the percentage of people who, over the age of 5, who speak Spanish at home. So not primarily Spanish, or not only Spanish, but Spanish is spoken in the home. So you can see Texas is the highest, followed very closely by California and New Mexico. Not very surprising. So if we look at the percentage of people who are over 5 who speak English very well, I'm not exactly sure how that's defined very well. But by state, again, this is in 2009. We kind of see that Texas drops from having 30% of people who speak Spanish to like 15% of people that speak English very well. So that would indicate a very, excuse me, a very huge language barrier for, our patients, especially if we're looking at the Hispanic population. So if you look further at studies of people, this is kind of an older study, but looking at studies of Hispanic adults who have limited English, you can kind of see that not a lot are very satisfied. So they tend to have a hard time 44%, have a hard time speaking with or understanding their doctor because of the language barrier. And of those who needed an interpreter, the percent who will get an interpreter was about 49%. That's probably a little bit better now that a lot more people speak Spanish, but the problem is that it's not always a professional interpreter. Usually we're using a staff member or a family member or something like that. So sometimes the information gets a little confused. And then the usual interpreter more or less tends to be the staff person or family and friend, like I said. Trained medical interpreters are increasing, but probably not as much as we need to have. But still, even with all of the translations and all of the interpreters, we're still having only 70% of patients say that they felt like they had a good communication with their physician. So that's kind of surprising. Okay. So what you have as a result of that are households that feel linguistically isolated. And this was, again, kind of an older look at the counties, but from 2005 to 2009. And again, you can tell that we're still looking in that South Texas region where we're having so many people. Again, you'll remember that it's not only the Hispanic people, but there are a geriatric population where a lot of people are growing in. And so we need to make sure that we are taking care of those patients there. So another barrier is education. Looking at the educational attainment in Texas in 2009, 79% of people had a high school diploma, 25% had a bachelor's degree, and about 8.5% had a graduate degree. Breaking that down by Hispanic and non-Hispanic white, about almost 30% of Hispanic had less than a high school diploma. Again, this was 2009, so these numbers have changed some with different programs that the state has opened up and different scholarships and things like that, but still an alarming difference between those two. So if you think about it, the degree of education in the Hispanic population has changed with our younger population who are just now going through school, through college, through graduate degree and all of that, which really would not pertain to our older adults unless they, had been here for some time. Definitely doesn't apply to the gentleman in our case, right? I mean, he didn't really have an education, and that's not going to change in his situation. So then looking at income and poverty level, median household income, you can see is kind of, let's see, San Antonio area, where's that? Is that Dallas up there? Looking at the darker purple areas. But if you look down in that South Texas region, let's see, we're looking at probably 35,000, which is not horrible in that region. I mean, Texas has a decent cost of living, but if you're an older adult on a fixed income, things can be difficult for you by the time you put in a home provider and medications and co-pays and all of that kind of stuff. So this is the percentage of people who are under 18 living in poverty. Again, we see that the darker colors, 40 to 55%, tend to come up in that South Texas region. So we have to think about the poverty level as well. In the case of our gentleman, he is on a fixed income. His wife, they basically get, I forget how much they get per month. But they're on a fixed income, and then the family kind of chips in and helps from time to time, which is why they don't have a home provider. They don't do the day program, and they have a very hard time getting all of his medications a lot of the time because of the copays and all of that stuff. Transportation becomes an issue as well. So looking at healthcare, insurance coverage is much higher in the Anglo or white population than in all the other groups. And then if you look at the Latino, which I guess is the mostly, well, I guess it's neck and neck with either none or private. And then public health care is about 25%. Unfortunately, I wasn't able to find where demographically that was, like a picture of what counties that was in. But, okay. So with Medicare, prescription drugs, there's special prohibition on certain drugs which are often prescribed to cope with mental issues. Even with the prescription, the only coverage Medicare provides for at-home medications is through Part D. Over-the-counter nutritional supplements, adult daycare, this is considered custodial care as opposed to medical care. And then respite care, except as described under the Part A, personal aid assistance, except as provided under the home health care benefits, which is very confusing, very difficult to manipulate, and a lot of people don't understand the rules of how to even ask for those things when they go to the physician. In terms of long-term care in a nursing home, Medicare may pay for up to 100 days of care in a skilled nursing facility, cover 100% of the first 20 days. For 21 to 100 days, the beneficiary pays a daily co-insurance amount. So that knocks out a lot of our population that need this type of care. Assisted living costs, these are generally not covered by Medicare, but the program may pay for short-term services such as physical and other therapies. And then they will pay for incontinence supplies. So even for taking care of our caregivers, to give them respite care, or if the, they're going out of town, or he suddenly becomes too much to stay at home or something like that, there's really not a lot of options that they have unless they're going to pay out of pocket, which is not an option for a lot of our families that we see, unfortunately. So this is kind of a busy slide, but I wanted to just kind of show, these are the medications that we call cognitive enhancers. These are the meds that we use for dementia. So you'll see Aricept, donepezil being the, what's the word, generic, and then Exelon, galantamine, Namenda, and so forth. And so you can see how many drugs are covered by their insurance plan or Medicare, whatever they have, and then how many are not. So all the ones that are in red are not covered. And then all the ones in green limits the numbers of pills that are covered in a period of time. So if you think about it, this puts a lot of limits on people, because if they aren't able to get their medications, then we're really not able to help them very much, right? And there's really not a lot that we can do. And then a lot of times people are put in situations where they've got to pick between like their Aricept or the lisinopril or the simvastatin or something like that. So that becomes an issue as well. So healthcare becomes a huge part of our disparity problem. So again, this is kind of a busy slide, but just Medicare may cover some of the following medical treatments, though it may sometimes deny payment for them, like home health care. So health provider, a home health provider, rehab care including physical, occupational, or speech therapy, mental health services, which is extremely difficult to get covered, but it's becoming easier as Medicare is cheating. And then hospice coverage, available for Part A, but if a physician certifies that the patient is terminally ill with a life expectancy of 6 months or less. And then if that patient happens to survive over 6 months, they get kicked out of hospice, and then we kind of have to go through it again. So that becomes another cycle again. Okay, so let's look at access and availability of service. Here's the projected ethnicity of people aged 65 and older, again. You can see that the Hispanic population is looking to increase. African American about the same, I guess, and white Texans looks to be decreasing. And this is the physician per 1,000 This is a physician per 1,000 of the population who are 65 and older. So you can see the red is that there are no physicians per 1,000 population. And that's like percentage, so there's physicians, so there's probably like maybe 1 or 2, maybe 3 in the county or something. Because these are very rural areas, so people have a lot of transportation problems, things are very far away, there's one clinic, there's one hospital, so. And then greater than 20 physicians is kind of, the metro areas there. But I think it's kind of alarming if you look kind of in the South Texas area that there are very few physicians in kind of this booming, aging population area. So, what does that mean for us as providers? So we should be providing culturally sensitive dementia care. So again, as Dr. Shedd had said before, not to kind of put a stamp on somebody and put them in a group, but to consider each person as an individual as well as a product of their country, religion, ethnic background, etc. To understand the linguistic, the economic, the social barriers, consider alternative to Western philosophy and practice. So things such as therapeutic non-disclosure, other ritualistic or spiritual religion type treatments. Again, important not to place everyone in a particular ethnic group into the same category. Respecting social and cultural differences, considering the family's background and experience in determining service and treatment plan. Consider the cultural perceptions of aging, caring for elderly and memory impairment. Understand the family's culture impacts their choices regarding ethical issues, especially end-of-life issues, talking about DNR, DNI, wills, and things like that. Considering the faith community as a critical support system, which is very important in our population. So for us, we should value the diversity, awareness, and acceptance of differences. Become self-aware of our own personal views, where we're coming from. Dynamics of differences, be conscious of the dynamics. Knowledge of client's culture and adaptation of our skills based on what we learn. So, here are some kind of caveats that I read while I was researching for this. So, when we say Hispanic Latino culture, we're talking about a widely diverse group from Spain, Mexico, Puerto Rico, Cuba, Central and South America. Mexican Americans constitute the largest group with the largest kinship ties to southwest part of the United States. They are the second largest minority group, and 1.5 million elders currently projected to be 13 million by 2050. So, in this culture, from the paper that I read, the family unit is the center of most activity and support. Care for elders is mostly provided by the extended family, so as in the case of our gentleman the daughters, the wife, grandchildren. Cubans, unlike Mexican Americans, are more likely to include friends in their definition of family, so you'll have kind of an even wider extension of support network. And Puerto Ricans are more likely to include non-blood kin in their family, so just really close family friends can be included in that. The majority practice Catholicism, although there are some members of Protestant denominations. They tend to seek emotional and strong spiritual support from their church or religion, spiritual denominations. And they take solace in religious beliefs to cope with stress. So doctors are viewed as authority figures. However, there is a delay of going to receive healthcare assistance, as Dr. Shedd had alluded to. They tend to be diagnosed later, they go in later. They receive the healthcare information, education from Spanish media. That was interesting. It is important not to confuse a person's country of origin. And then often lack transportation. Again, that would be more related to kind of the rural areas where they're kind of out and they have to travel 15 miles to the clinic or 10 miles to the grocery store or something like that. And we're talking about some elders who have difficulty doing that, or they rely on other people, and so that becomes a burden for them. In particular, the early stages of cognitive impairments is viewed as normal aging. And they kind of look at it as, oh, that's just crazy grandma. But yeah, she's just losing it, and they all cover for her or whatever. Because digging down deep in the case that I presented earlier, he'd actually been having problems for over 10 years. And they just kind of figured it out maybe over the last 2 years that he was getting more and more difficult to take care of. Maybe we should do something about this. So would the outcome have been different? I don't know. But and then having mental illness may be looked at as a punishment for past sins or bad blood. They may not seek out services to avoid shaming the family. And then sometimes people will view mental illness or dementia as being attributed to nervios or mal ojo. And I think we will stop there. Yeah. Does anyone have any questions or comments? No. No, he was not.
How did it work out for him? Did the family take care of him?
Yeah, so we had multiple discussions about trying to do health care and all of that, and they just weren't able to afford it. And so they got together with neighbors and family, and they worked out kind of a system for everybody to pitch in and help. They didn't really have a problem with meals or transportation because people were already doing that anyway. And then they were initially against medication, but it got to the point where we needed to do medication. So we did that, but several times they actually brought their priest with them, and they would do blessings and that kind of thing. But so that was an interesting, because I never had that.
Did a case manager help out as far as getting cheaper medication? You know, Walmart has programs for getting generics for like $4 for a month supply. Did somebody work with them for those services?
Yeah, so that's a great question. I don't actually have a case manager in my clinic, so I had to do that. And unfortunately, the medications were not on those lists. So we had to substitute with the best we could do. But I was able to find like a volunteer service through the Catholic Charities where they let them go to the day program, and so he could participate in all of that. And it was like a minimal fee, or they let him like go and pay for like every other session or something like that. So he was able to, you know, the wife was able to kind of have the days off or something like that. Yeah. But they worked out respite care for the family. We got them into a support group, and so it worked out. Okay. Anyone else? All right, thank you for your time.
concludes today's conference, day one, summer student aging. Tomorrow, 8 o'clock, we'll do it all over again. 8 new speakers, 8 new topics. And again, if you have any questions concerning with the CEUs, I'll be here for the remainder of the day. If not,